Okay, I think we're going to get started. So welcome to this summer webinar today. This is organised by the North Thames ARC, which is Applied Research Collaboration, and we're focusing today on qualitative methods in implementation research. And there's been lots of interest in this webinar, and it's great to see so many of you joining us. Could we move on to the next slide? Just a few housekeeping things for this session. So if you could just keep your settings, your audio off, there will be an opportunity later to ask questions where we'll invite people to, but if you could keep them off while the speakers are speaking. Please feel free to use the chat. We find that's a great place to engage with the things that the speakers are talking about, so we'd love you to do that. When we come to the Q&A session, if you could put your question in the chat, that would be great, and we'll pick them out and then ask you if you'd like to ask your question in person, and we can unmute then. We are recording this session. I hope that's okay with everyone, and we'll also be tweeting about the event. So if you've got things you'd like to share on Twitter, we'd like you to invite you to do that. So can I just say a little bit about the format of this session? So we're starting with 60 minutes of presentations. We've got two fantastic speakers to talk to us today. Then we're going to have a 20-minute discussion with the speakers and also with two other members of our team at the ARC. And then we're going to have a session of quick Q&A. So if you can put any questions you have for that end of the session in the chat, and then we'll pick them up, that would be great. So in terms of what we're going to cover in this webinar, we're going to start off with Professor Anne MacFarlane and then Dr. Cory Bradley, who are each going to talk for around half an hour. Then we're going to have a discussion where Tiyi Morris and Fiona Stevenson are going to join us for a discussion about things that the presentations have stimulated them to think about. Then there's a Q&A session, and then we'll have some closing remarks. So we're going to get going straight away with Professor Anne MacFarlane. It's fantastic to have Anne with us today. Anne has considerable experience as a qualitative researcher and has worked in some really interesting roles. And is currently coming to us from Ireland. She has also contributed to the development of normalization process theory since 2004. So a great opportunity to hear from her about how she's done some pioneering work to pair participatory research approaches with normalization process theory. I'm really looking forward to hearing her give us her presentation on that work. So I'm going to hand over to Anne now, and she's going to share her screen. Thanks, Anne.
Thank you very much, Annette. It's wonderful to be here, and I'd also like to say thanks very much to Professor Carl May for the invite and making this possible. So I'm just going to share my slides. If you could just let me know that you can see that okay?
Yeah, that looks great. Okay.
Yeah, so what I'd like to do is share a qualitative implementation science journey with you. And to do that, I'm really going back to the year 2000 and we'll be telling you the story of certain journeys and pathways in my career that speak to the goals of this webinar. The work that I'm presenting is based on multiple projects with different teams of people in different countries. So some of them are listed here, and it's just to highlight that work like this is always done in interdisciplinary, interagency, collaborative teams, and it's just always been a real privilege to work with the different teams that are showing here. So in terms of the goals of the webinar, when I was speaking with Carl about this, he explained that it was important to in the webinar to promote qualitative research on evidence, translation and implementation science, and to think about the role of conceptual models in informing qualitative research on these topics. And I guess for me, as I say, that really mapped onto my own journey as a qualitative researcher. So that's what I'd like to share with you today in three parts. The first is to share with you my experience of qualitative research about telemedicine and its translation into practice. The second part of the journey is where that progressed into qualitative theory building about telemedicine implementation processes, leading to a third part of the journey, which was theoretical, qualitative, prospective, participatory implementation research. And this time the topic was shifted from telemedicine to improving communication with refugees and migrants. Now, there's a bit of a thread to this journey, and it's about London buses. So let me explain. I was in 2000, had finished my PhD, was working as a postdoc in Ireland, but very keen to expand my experience, and I wanted to work abroad. And I was really excited and privileged to get a job in University College London in 2000 as a research assistant as a qualitative researcher. So I had never been to London. I knew nothing about telemedicine, but I did have a PhD experience in qualitative research, so I was delighted to take the plunge and move to London. It was important that I first of all figured out what telemedicine was, and that was basically it's about remote medicine and using technology. And of course now, perhaps just after COVID, more of us are more familiar with telemedicine because of the role of telephone and other virtual consultations during the COVID pandemic. But at the time in this work that was starting in UCL, telemedicine was conceptualized as a complex intervention as per the MRC guidance at the time. So this means that, you know, it's a service or an innovation that incorporates a number of different components at once, like policy developments, resource allocation, administrative actions, clinical actions, and so on. It also reshapes actions by and interactions between different actors or stakeholders. And as a complex intervention, it's also about introducing new roles, responsibilities, and tasks to healthcare settings. So the Virtual Outreach Project was a really landmark piece of research at the time, led out of UCL by Professor Paul Wallace, and it started in 1995 and ended around 2002. And Robert Harrison was the sociology qualitative researcher associated with that project. The Virtual Outreach Project, after feasibility and pilot studies, was set up as a pragmatic randomized controlled trial. The aim was to look at new joint medical consultation service that was being developed as an alternative to standard outpatient care. So what that meant was that over 2,000 patients were recruited to the trial by their family practitioners, and they were referred to 20 hospital consultants in 6 different specialties: ENT medicine, general medicine, gastroenterology, orthopedics, neurology, and urology. But in the trial, half of the patients did go through the standard outpatient appointment. They traveled to the hospital and they saw the consultant by themselves. But in the new joint medical teleconsultation service, the patient went to their local GP surgery, sat with their GP, and had a virtual video link with the hospital consultant and had a 3-way interaction. Now, the findings of the trial were that patients were satisfied, and all of these findings were from quantitative measures. There was evidence that patients were satisfied with the teleconsultation service. There was evidence of reductions in tests and investigations. There was evidence, unexpectedly, of increased rates of follow-up appointments, particularly in ENT and orthopedics. And at this point in the trial, there was a lot of, I suppose, excitement about the findings, and it was important to see the quantitative evidence. But what was clear was it wasn't really clear about the reasons for patient satisfaction, the reasons for these reductions and increases. And also the wider literature about telemedicine at the time was full of examples of pilot studies and trials like this that, even when they had positive results, didn't endure past the lifetime of the trial. And so the Virtual Outreach Project team wanted to explore more about the reasons for the findings and to understand more about the likelihood of endurance of the new service. So that's the outcome paper from Virtual Outreach Project, if you'd like to have a look. So that led to the qualitative research that I was hired to join the team. The goal of this research was to understand the practices and processes of joint teleconsultations. And we were particularly interested in examining organizational, social, and educational issues that were going on in this innovative 3-way teleconsultation. So in terms of data generation, we used interviews, qualitative focus groups, and video consultations, and we amassed a large amount of qualitative data. At the time, so this is 2000, at the time, qualitative research was gaining momentum, I think, and you could say maybe even gaining credibility. This was a paper I became familiar with during my PhD, and I would have referred a lot to in my time in London. It was really making the argument that qualitative research reaches the parts that other methods cannot, and that qualitative methods have a long history in the social sciences, and they deserved a more prominent place in health services research, because through the 90s, there was still a lot of sense of, competition between quantitative and qualitative methods. Quantitative methods always won, they were always considered better. And, there was a sense of disparagement about qualitative methods and what they could offer. And this shift in thinking, I think, through the 90s was, look, they do different things. They're based on different paradigms. They ask different questions, and we will learn more if we combine them. So with all that in mind, in the qualitative component of the virtual outreach project, we used an inductive analysis, which meant we didn't go in with preconceived ideas about what kind of data or findings we expected. And we used a framework analysis, which was a very systematic and rigorous and 5-step approach to the analysis of the data from the interviews and the focus groups. And it was very interesting. We ended up with a very, very long list of themes about the patient and the doctor experiences of being in joint medical teleconsultations. We knew an awful lot of rich detail about time issues, safety, role clarity, technology, communication between professionals, communication with patients, logistics. The list was actually longer. I was looking back at trying to find the paper files I have of this to prepare for today, but I wasn't successful. But we had this sort of extensive, rich, contextual detail about what all the different parties thought, and under this sort of multiple headings. So we were pleased, we learned why patients were satisfied. For example, patients quite liked hearing 2 doctors talking about them, which was possible in a triadic joint teleconsultation. The reduced tests and investigations were sometimes due to the fact that the patient's GP could fill the consultant in on details of their history or other tests and investigations they'd had in the past. And that meant then that there was a more refined use of test investigations after the joint teleconsultation. The increased follow-up, we learned, was really because in joint teleconsultations that relied on a physical exam, the trial had been set up such that the consultant would guide the GP to do the physical exam and give the feedback to the consultant so he or she could decide what to do next. And what we learned was that actually didn't feel very clinically safe or satisfactory for the consultants, because they were used to knowledge themselves from their own hands-on examinations. And we had a sense of some of the issues around endurance, because obviously throughout the themes there was as many negative as positive experiences. And so technology on the one hand was very positive because it was time saving. It was very negative because if it breaks down or it disrupts, then the whole consultation fell apart. So at that point we had a sense of accomplishment, but also a sense of some unanswered questions around endurance, as I mentioned, but also some sense that we knew so much, but we still couldn't come down to very definitive appraisals of what mattered the most, you could say. And a lot of the last set of data analysis meetings we had turned into sort of internal debates or discussions about which one of these themes mattered the most, And then I started to feel this isn't very satisfactory. We have a huge amount of data, and now we're somehow lost in that, trying to figure out exactly what does it all mean. And this brings me to the second part of my journey, qualitative theory building about implementation processes. At this time, the London bus was for Professor May. At this time, Carl was working in Manchester, and he was very involved in telemedicine research as well. And we learned about each other's work, and he came to visit the virtual outreach project team in London. And that led to this paper. So Carl was working with Tracy Finch and Francis Mayer, amongst others, and he came to meet Paul Wallace, Robert Harrison, and myself. And through that set of discussions, we formed what was called the Telemedicine Adoption Study Group, and Carl led us through a most fascinating process. And I can tell you it was one of the biggest learning experiences I've ever had in my career as a qualitative researcher, watching what happened next. The Telemedicine Adoption Study Group, again, I went back to the files and pulled out the paper to say, how would I explain it to you today? And to be honest, it was very well written. So I'm just going to share some text from the paper with you. In the paper, we said in this article, our objective is to move debates about telemedicine forward, and that our central argument is while there's lots of summative evidence available about the end point of telemedicine evaluations, another important field of inquiry has been neglected. And that was exactly our experience at the end of virtual outreach. To understand the failure of telemedicine systems to normalise, to become routine across different applications, we need also to attend qualitatively to the formative processes that characterise them. And that is how we will understand how and why many services fail to endure. Our objective is therefore to make the case for a complementary model of telemedicine evaluation that uses qualitative research methods to understand these formative processes. And what we did at this point was combined data from 3 studies. So there were 2 studies that Carl and colleagues have been involved in, called in this paper Telemedicine 1 and Telemedicine 2, and then the Virtual Outreach Project. And together, this was a data set drawn from 11 sites across the UK. In each of the individual sites, we had done retrospective and cumulative analysis of longitudinal qualitative data. There was a combination of observation and semi-structured interviews, producing the substantial body of data relating to 582 discrete data collection episodes. And then, while the data had all been analysed separately, as I just shared with you there, the findings of our individual analysis from the London work in virtual outreach, we now engaged in this cumulative, iterative analysis conducted by constant comparative method. And from this, we had then the ability to develop an outline model to think more about the data. So I think what was powerful at this point was one of the critiques pitched against qualitative research often is, of course, it's site-specific or place-specific, and the data sets are small, and therefore any kind of, transferable findings or the authenticity of the data for other sites or settings is questioned. But of course, what was powerful here was the ability to bring smaller studies together and end up with a larger data set that could transcend those critiques. Now, the outline model, just to say, was very much driven by Carl and his analytical abilities that really led to the learning for all of us, because this was this massive light bulb moment for me that as a qualitative researcher, I had good skills at the time for conducting qualitative fieldwork and doing a thematic analysis, but I was stuck at the level of synthesizing the data in terms of the patterns about what people were saying and what people were talking about. So if you remember back to that list I showed you a minute ago, people talked a lot about time, people talked a lot about technology, people talked a lot about communication, and I had the ability to synthesize the data around those patterns. But what happened next here was this much more advanced level of analysis, which was, it's not about what people are saying, it's it's understanding what is it actually about at a higher, more conceptual level. And suddenly this massive long list of themes from the London and the combined work was synthesized into 4 higher level conceptual themes. And they led then to 4 propositions that you could start to say, well, the evidence is if these features are in place, the likelihood of a service enduring past the life of a trial will be stronger. So it sort of moved into this more conceptual and predictive capacity, if you like. So briefly, the propositions at this point in the early work were, proposition 1 was about the value of a positive supportive policy environment that led to infrastructure resources for a telemedicine service. Proposition 2 was about that if there was capacity to make changes to the organizational setting, that was very good for integrating telemedicine services into the structures, like if there was capacity to amend appointment systems. Proposition 3 was that it was important to enroll all key actors into the work, but also that they were all clear about what they were doing. So clear role divisions of labour and clear functional role identities. And then the 4th proposition was that because this was a new way of working, that the actors involved. I was just describing the value of this analysis, which has lifted it into more conceptual analysis and less about what people were saying and more about, you know, what it actually meant in a more conceptual terms. And it led to the development of the first 4 propositions that could be used to predict if a service would endure past the lifetime of a trial. I don't know if you heard me describing the 4 propositions. And then, so they were relating to the importance of the policy context, organizational adaptation, the enrollment of actors with clear functional identities, and that people could integrate new ways of working. So this led to the development in the first instance of normalization process model, which was subsequently developed into normalization process theory. Now, there's obviously long lectures to describe those 2 in and of themselves, and I'm just referring them here, and obviously you can read the papers in more detail, but I can give you some insight to them as I go on. So normalization process theory has 4 main constructs about coherence, cognitive participation, collective action, reflexive monitoring, and they relate to whether or not a new way of working makes sense, whether all the actors are engaged, if the new way of working can be incorporated into daily routines, and if it's worth it to use the new way of working. The scope of having NPT changed the nature of the qualitative research that could be designed and conducted, because now there was an a priori conceptual framework that could be used to plan data collection and to inform deductive data analysis. So we didn't have to start analysis thinking, well, you know, we know nothing about what might matter. We actually had quite clear guidance from NPT. And there is an NPT toolkit available for use, and it is used by researchers, including qualitative researchers, in multiple ways. This leads to the 3rd part of my journey. And the London bus connection here is that as I was finishing my time in London, which was 2002, I was aware that in Ireland there had been a significant increase in inward migration. So as many of you will know, Ireland is traditionally a country of emigration, but through the late 90s and 2000s, there was a significant shift with more refugees and migrants moving to Ireland, and now 17% of the Irish population is born outside the country. And as an Irish person, now with experience of living in London, moving home, I realised I wasn't as, I was more drawn to doing research about refugees and migrant health than telemedicine research. And I was particularly interested in refugee and migrants' experience of communication in general practice consultations, because the healthcare system in Ireland has never been set up for cultural and linguistic diversity. So this was the next, this was a bit of a fork in the road, you could say, on my journey. Just very briefly to sort of put you in the headspace of refugee and migrant health and the issue of communication, because we've been talking up to now about telemedicine. I'm just going to ask you for a moment to imagine that you're a doctor, you're sitting in your surgery, patient comes in, you're looking at your schedule, thinking of about 10 minutes for this patient, and the patient says this. Or another patient follows and says this. So the first patient is Polish speaking and is telling you, I have a pain in my chest. The second patient is Portuguese speaking and is saying, I have a back pain and cannot sleep. And what we know from the literature in Ireland and in many international GP settings, doctors and patients don't have access to trained interpreters to help them navigate that language and cultural difference, and to help them decipher the significance and the severity of these symptoms, which could be very minor. Pain in the chest could be a bit of indigestion, or it could be, you know, something much more serious and heart related. The work we did in Ireland at the beginning was interested in logging the nature of the experiences of refugees and migrants and GPs in this regard. And just unsurprisingly, the data was very like the international literature. Refugees and migrants said, if there's no trained interpreter and you cannot explain the problem, how can you clarify the problem? How can you get quality care from a GP? We talked to GP registers who were GPs in training telling us, you know, when they come in, you're not going to be able to communicate as effectively as you would with someone who is English. And they're not going to get the GP service that you want to give them because of that. At this point, I drew on my experience of telemedicine research, and I understood that I could conceptualize the interpreted consultation as a complex intervention too, for the same reasons. It incorporates a number of different components, it reshapes actions and interactions, it introduces new roles, responsibilities, and tasks. So I suddenly could see I could take so much of what I'd learned from telemedicine research to study the implementation of interpreted consultations. There was a free pilot service in the Dublin region in Ireland in 2008-2009, and it had been asked for by the GP community, made available to the GP community, and then it wasn't used by the GP community. The uptake was incredibly low. So in this work, we did a qualitative evaluation using MPM to analyse the levers and barriers to uptake of this GP service. We did an inductive analysis, and then we mapped the findings onto MPM, again, to benefit from MPM and the conceptual depth it could offer. And we've written quite a detailed paper about this because there were quite a few aha moments here as well, whereby the original list of themes from the inductive analysis was long and detailed, but mapping them onto MPM did heighten our understanding of some of those nuances. So for example, again, in relation to using interpreted consultations, the GPs talked a lot about how time consuming it was, and time being a problem because it costs them money and they don't have resources for interpreted consultations. And we realized sometimes they were talking about very much the contextual policy side of things, whereby there are policies that support the provision of resources to GPs to use interpreters. So that was one conceptual element. But sometimes they were saying, well, these consultations are long, and what they meant was they feel long. They're interactionally difficult, again, which was about them having to consult in a triad with a patient, interpreter, and doctor, rather than the classic dyad of doctor-patient. So again, we could see the ways in which the conceptual model lifted the qualitative analysis and the depth of understanding. But at the same time now, I was bothered, I suppose, because I thought, well, I don't really just want to keep logging descriptions of the problem, no matter how conceptually interesting that might be. And the issues here, of course, are that it is a human right to have access to healthcare. We know that access to healthcare is a social determinant of health, and there's increasing recognition that migration is also a social determinant of health. And so it was clear to me that from an equity perspective, we need interventions that lead to adaptation of health services so that they are accessible to refugees and migrants, and that they are functioning in linguistically and culturally diverse societies. So from that point of view, I became interested in the idea that perhaps we could move past using MPM or MPT to describe levers and barriers, and we could use MPT to shape implementation journeys. And there were two elements to this. One was, well, what about using MPT prospectively to set up, monitor, and intervene in an implementation journey as barriers come up? And now I suppose we have the sense where we know the kind of barriers that are likely to come up, so we can almost be ready to think about how to intervene. But also MPT is a theory, it's not a methodology. So what would happen, we thought, well, if we combine that theory with an action-oriented methodology, and that was about engaging with participatory methodologies. So this set of thinking led to an EU-funded study called the Restore project, which was conducted with colleagues in Scotland, England, Austria, the Netherlands, Greece, and Ireland.
And you've just got a couple of minutes left.
Great, thank you. So this is our study protocol, if you'd like to read it. And this is the paper that we published, which really summarizes why we thought it was a good idea to combine MPT and participatory learning and action research, which was the methodology, the participatory methodology that we used. Very briefly, both MPT and PLA have been developed in response to multiple failures to implement innovation. Both are located within the broad frame of social constructionism. MPT has a focus mainly on professionals and doesn't explicitly address power dynamics. And PLA is very much about power dynamics and power asymmetries, but doesn't have the insight of implementation processes that MPT could offer through its systematic theory building process. So we then took the normalization process theory, the idea of interpretive consultation as a complex intervention, and we asked these questions. And as I say, we were monitoring the work from the very start. We first analysed the healthcare and policy context in each country to understand how supportive or not it was for the implementation of trained interpreters or other interventions to support communication between refugees and migrants. We used MPT to identify relevant guidelines and training initiatives for improving communication in each of the countries. Then the migrants and other stakeholders in 5 primary care settings used PLA techniques to select a guideline or training initiative, and then they implemented it in their own clinical setting. And very much the theory, we were interested that as we followed the journeys unfolding in real space and time, the stakeholders thought of almost all the kind of work that they needed to do. And we learned that they did think the guidelines and training initiatives made sense. They were engaged and they drove their implementation projects forward, and they really valued PLA methodology and technique for supporting dialogues and discussion and learning between them to make that happen. They were able to introduce new ways of working in their primary care settings. There was evidence, for example, of enhanced empathy for refugees and migrants, decisions to lengthen consultations with refugees and migrants. And they also did evaluate the impact of using these new ways of working in primary care and felt that they were valuable. So the bits in red are about some of the endpoints that we learned, that the stakeholders in this participatory implementation process had a lot of problems and barriers to solve along the way, and they were able to do that very successfully, apart from when macro level factors intervened and meant that it was beyond their control. And also, I would just highlight again that we did need MPT to alert us to the importance of the appraisal work that comes within an implementation journey. So I'm coming to the end now. Just to conclude, I suppose I'm excited that the next steps with this work will be more qualitative collaborations with Carl, which I'm really looking forward to through a new project called TRIPPER. And it's about, more thinking about taking theoretical knowledge and then the methodological partnership there to make implementation processes as participatory as possible. I'm also interested in how MPT-informed tools can be used in practice to implement interpretive consultations. There's some important contextual changes here in Ireland in relation to the Irish Human Rights Equality Commission and new legislation that puts responsibility on our health service executive to make these interpreters available to refugees and migrants. So contextually, things have changed quite dramatically in the last 5 or 6 years. And also the World Health Organization migrant health team that we're working with are interested in how we can involve refugees and migrants more and more, both in research and policy development. So I think there's a lot of exciting opportunities and developments of this work coming down the line. So to summarize, the webinar goals that I mentioned at the beginning were about promoting qualitative research on evidence, translation and implementation science, and thinking about the role of conceptual models in informing qualitative research on these topics. So what I hope you've gleaned or taken from this talk is that qualitative research was essential to uncover the complexity of processes involved in the translation of telemedicine into practice. Qualitative theory building that combined findings from qualitative studies led to the development of a model to conceptualize key propositions, not just about telemedicine in the end, but about implementation processes much more broadly. And the theoretical, this is a bit of a mouthful, theoretical, qualitative, prospective, participatory implementation research about improving communication with refugees and migrants revealed that we need to think a lot more about equity and power to optimize implementation processes. Thank you very much for your attention. Apologies for this glitch in the middle, and I look forward to the discussion.
Thank you, Anne, and thank you for persevering and getting back to us so quickly. And I think a lovely segue into Cory's presentation. So I'd like to invite Dr. Cory Bradley to join us next. He's joining us all the way from Washington University in Missouri. And I'm really interested to hear his fascinating account of thinking about implementation of health interventions as a tool for justice making using normalization process theory. So you can see those parallels there to what we've just been hearing about from Anne. So I'm going to hand over to you now, Cory.
Fantastic. Hello. Yeah, okay, good deal. Can folks see that first slide, the title slide? Oh. Hello?
Yes, that's fine.
Okay, just making sure. Yeah,
not on presenter mode.
It's not on presenter mode. Okay, this is what I need to figure out then. Thank you. All right, there it is. Are we there?
It's still not showing as a full screen.
Of course, this would happen. Okay.
It was fine before, wasn't it?
Yikes. I think there's some kind of setting that I did not. This is not cool. What is that?
You stop sharing.
Yeah, thank you.
And then try reshare.
Okay.
And share the presentation rather than your screen.
Oh, I think this might be it.
Great, that's at the start. There you go.
Great. Okay. Everyone must. I need a couple of votes of I did try this. I practiced this, everyone. So anyhow, thanks so much. And thank you so much for the presentation. It was like a wonderful, wonderful to proceed this kind of exploration that I want to lead us into. I'm a postdoc, and so I like to hide behind that and say, I get to kind of like play in the sandbox. I'm not like a real professor of faculty yet, so I get to play with these ideas. I was formerly a pastor and worked in ministry, and then came to my doctorate work in public health a little later in my life, and over the last couple of years, have been working in implementation science, and was introduced to normalization process theory by my mentor, Elvin Gang, and then we connected with Carl, and since that time, it's just been really awesome thinking with Carl and Elvin and Alice Hillis and Whitney Irie, Dr. Whitney Irie. These are all kind of thought partners in the space of normalization process theory, implementation, and equity. And want to also extend my gratitude to Carl. He's just a phenomenal kind of person and support to me. And I go around in my work describing to other folks when we talk about things, I'm like, I'm an acolyte of NPT. So I'm always talking about NPT, and then people are like, what is that? And so it's a great opportunity to do that. So anyhow, here I want to again say, I want to take you through kind of some thinking and some ways that I'm putting together ideas and hoping to move into kind of an empirical validation of these ideas. So as I said, Anne clearly showed us the conceptual basis. showed us the empirical development around those concepts. And then I'm kind of working from taking those concepts and eventually moving to a kind of an empirical sorting of these ideas. But I forgot to do an outline. So let me just quickly say that how I'll move through this is kind of expand, like talking through the definition of implementation that's offered through normalization process theory, and then some insights from the literature about the need for theorizing to explore the intersection of equity and implementation practice and research, and then to talk a little bit about health equity, how I operationalize it, going through next an exploratory conversation where I want to attempt to link my thinking around MPT with an evaluation of equitable implementation, and then add an engagement with critical race theory, so federating critical race theory to think about what it might offer to exploring what equitable implementation practice and research might mean. And then I'll conclude with the assignment that we have here of amplifying the role for qualitative implementation research in the pursuit of equity. And I begin with this definition of implementation, which has motivated my thinking at the intersection of implementation processes and health equity. And the definition really resonates with ideas I've been developing because it offers a more explicit sociological orientation to implementation, acknowledging that implementation is fundamentally a social process. And we're familiar with the other characterizations of implementation. They take on a predominantly psychological and behaviorist orientation or organizational psychology management perspective. And I pick up this defining framework through the work of Kalman and colleagues as an articulation of normalization process theory, which we understand and some may not, but is a middle range theory that is used to explain and evaluate processes involved in the integration, embedding, and normalization of an ensemble of activities. For the purposes of our conversation, those activities and an ensemble is related to health interventions, primarily at the population level. And with MPT, it derives from social action theory, which asserts that society is a construction of interactions and meanings given to it by its members, and holds that implementation, therefore, is fundamentally a purposive social action and frames implementation as actioned through meaning and significance. And so largely the idea is that social action theory interprets structural changes by considering meanings behind those actions. We essentially understand human actions and social change by understanding the meanings that are given to those actions. So that's where I kind of dive in to understand what MPT offers. And as it goes in MPT, sense making figures prominently and mobilizing the collective action and collaborative work that's involved in shaping implementation processes. And I also want to just say that I use slides, not just necessarily to talk from, but as a bit of a backdrop. I kind of have a talk that I have crafted, and then I use the slides to kind of give your eyes and something to look at while your ears listen to me as I go along. So, all right. So in the US and globally, I think we've seen a groundswell of research in the field of public health and healthcare delivery. At least in the States, it's very much been triggered by the disproportionality of COVID's impact on marginalized communities, and has been heightened by outrage at state-sanctioned murders of Black and brown bodies by police, led by movements such as Black Lives Matter. All of these have laid bare the root of health inequalities. And you may even be aware that the US Centers for Disease Control and Prevention have declared racism a serious public health threat. That was done in 2021, which has intensified analytic investigations of racialized context as complicit in the proliferation of health inequities among racially minoritized populations. And some of that work has engaged anti-racist and decolonial scholarship to theorize inequity in health outcomes. So I wanted to call your attention to this particular slide, this was an article in the Stanford Social Innovation Review where I have this question mark because they say that, you know, they suggest that we need a blueprint for equitable implementation, saying that that blueprint does not yet exist. And so I spoke with a colleague of mine there, as I mentioned, one of my kind of collaborators and co-conspirators, and asked her about this notion of what's your sense of whether the veracity of this, that there is not yet a blueprint. And she shared these ideas. Let me also just say, first of all, to your right, you'll see a graphic from that article where they kind of summarized from the articles that they had that were based in practice around equitable implementation, that they felt like these were the factors that were kind of the essential factors for successful equitable implementation. And in conversation with my friend and colleague, Dr. Whitney Irie, she was suggesting that there's a potential danger of having and seeking the blueprint because it can be reductionist and may result in a lack of careful thought in the exercise of our research, a kind of a taken for granted, a convenient explanation, and would then be less useful to the field to assert a singular approach to equity in implementation science. And in fact, maybe a blueprint sets equity as something kind of outside of or separate from implementation as an added feature, when really equity is best thought of as integrated and embedded throughout the science of implementation, research, and practice. In a commentary published last year on the utility of critical theories to advance health equity in implementation science, Claire Snellrud and colleagues note that many implementation theories, models, and frameworks still don't explicitly consider upstream structural factors that result in equitable adaptation or implementation of interventions, but those that do, and I think we're seeing increasingly frameworks being used in that way, they tend to focus on power dynamics, shaping clinical interactions, optimizing stakeholder engagement in implementation, designing multi-component interventions for populations experiencing systemic disadvantage, and strengthening policies to improve social determinants of health. But on the whole, as it pertains to attending to racialized contexts, it could be argued that implementation frameworks tend to be rather agnostic to the issues of inequality, power, social conditions of oppression and marginality. And this is really a significant consideration given that those models, and you know how we love our models in implementation science, they guide the framing of research questions and our choice of data collection instruments and the analysis of the data, and are used to generate strategies that achieve a fit between the implementation process, intervention components, and the context of implementation. So not really having TMFs, it's short for theory, models, and frameworks, having them unable to speak to those critical issues can be limiting. So in this presentation, what I want to do is present for your exploration, with you, an emphasis that I've been cultivating concerning implementation of interventions using normalization process theory federated with a grand theory, which in this case will be critical race theory, to theorize about disparate health outcomes and implementation outcomes resulting from systemic racism. And I have this, but I'm not sure that it's really necessary now that we've engaged the conversation to talk about how a mid-range theory can be used to kind of in this bidirectional route to explore grand theories and use the grand theories to kind of strengthen the mid-range theory, and then the mid-range theory being able to even expand those kind of grand theories. And as you can see here, the empirical findings far to your left are a part of this process, and that's the space that I am moving into, have yet to do so, but I'm engaging in a level of theorizing. But relevant to this exploration is a particular critique that Carl and colleagues cite in their 2016 paper on implementation and context, which is that MPT places an undue emphasis on individual and collective agency without explicitly locating agency within and as shaped by the organizational and relational context in which the implementation occurs. And what I hope to demonstrate is joining MPT and critical race theory and its anchoring tenet regarding the ordinariness of racism opens the possibility further for an analysis that is inclusive of this bidirectional influence of racialized context on the implementation process and actors or agents in that setting. Because after all, as critical race theory affirms, ultimately practice is shaped by and also serves to shape the structures that we are in. So Mays and colleagues respond to the critique of inattentiveness to the relationship between agency and context by just noting that there are studies in using MPT that focus on contextual and relational integration, though not aspiring to provide its own discrete theory. And they say that rather MPT is poised for federation with other theories that have those social problems at heart. And so this is kind of a foundation for how I'm thinking and using MPT and critical race theory. And this notion of theorizing that happens. And so hence the title, Situating Implementation Science in Resistance through utilizing implementation theorizing. And I hope you might agree that there's a relevant consideration for this webinar's focus on what qualitative methods in implementation research offers. So I don't, given the transnational, transcontinental texture of our conversation, I didn't want to take our understanding around inequality and inequity and health equity for granted. So that's just to say that I really ground my exploration of health equity in implementation, utilizing the conceptualization that Paula Braveman espouses and Dr. Kamara P. Jones proffer, and which in short is that health equity is a matter of not just outcomes, but about processes. It's about the assurance of conditions of optimal health. It's about the removal of obstacles, improving access to the conditions. And typically, I think a lot of times we think about health equity as in we want parity of outcomes, but I think this offers something different for us to consider and think about in the implementation process, that equity and health equity itself is a bit of a process in and of itself. And how can implementation research capture that best? And Jones argues, right, that health equity is not a goal, rather it's the assurance. And so there's a sense from these definitions around the embeddedness of health equity as a value-laden process of an ongoing assurance of conditions for optimal health as the anchoring commitment when we're intervening on population health, which I think is well beyond the pale of a singular focus on parity of outcomes, health outcomes. So again, that question is, how do we capture that in strategies of implementation? So accepting this notion of health equity means that there's an ethical responsibility upon health services delivery to facilitate equity through its implementation processes. And so here, I want to do a little bit of linking, and this is a slide that Carl shared with me early in our conversations on Twitter before we really started working together and talking together. And I was thinking about health. I called equity also health justice. And so I think NPT is really well suited for evaluating, implementing with equity. It brings an emphasis to the relational nature of implementation processes as a social process. And I argue that systemic oppression such as racism, sexism, homophobia, transphobia at core can be characterized as problems of social relations that manifest through relational context. given that collective action and collaborative work ultimately power the arrangements that characterize an implementation process. So it seems fitting to utilize MPT constructs to analyze how we can mobilize configurations of cooperation to help us explore and understand how a practice is normalized or fails to normalize in a given social system. The thinking here, in the case of racial equity, is that agents of implementation collectively construct their actions as, quote, pragmatic, strategic responses to the circumstances of a racialized context and as expressions of commitment to their values. And that's well linked to MPT's analytic goal of sense-making and meaning-making, which drives implementation processes. Thus, for example, perceiving racially equitable implementation through collective action requires exploring how implementation processes and their racialized context shape each other. And we might even think of equitable implementation of interventions as technologies in and of themselves that have the potential to transform the system they are placed in through their interaction with context and the capabilities that are created from this entire dynamic interaction. So this leads me to a particular phrase that I'm really invested in, that I've developed and kind of build my research program out of, which is implementation as a tool for justice making. And this is my approach at theorizing in ways. And so it's the notion that implementation planning focuses on operating within existing systems, but rarely considers the production of that environment to be a social process that can influence the work. So the work that we do in developing strategies might be able to be used prefiguratively to develop or to realize the kind of just world and just order and equitable order that we hope for. And implementation strategies, as they are ways to create fit between an intervention and a specific context, they do that by optimizing the outer system so as to maximize fit, or it could be by optimizing the intervention so that it fits the context. I think a lot of times we think about adaptation to the intervention itself, but I think it's time for us within this notion of implementation as a tool for justice making to think about ways that implementation strategies help us to get outside of the intervention itself and begin to tinker in our world, to change our world and think about how the world needs to be fixed in ways and not making individuals who experience disparities the problem. So interventions as technologies have the potential, is my assertion, to transform the system because of this interaction with context and the capabilities that are created from that interaction among the implementing team. So I sort of moved from Carl's notion of and this definition of implementation as the translation of strategic intentions to say that I'm thinking about what I'm calling kind of a translational framework for advancing transformative implementation. And that is essentially inviting a disruption of the status quo. How implementation does that? How does it facilitate the embedding, integration, and sustainability of that very virtuous strategic intention that we have from health equity as a definition through social processes of collective action and collaborative work that prefigure and contribute to a much wider social change. And so that implementation carries the strategic intention, which involves the identification and the displacement of conditions of injustice. And that is, in essence, what health equity, the definition I shared with you, is about. So I envision using NPT to uncover a framework for advancing what I call a transformative implementation. So I want to engage a little bit of the methodology that happens within MPT, because as some of you may know, and others may be learning here, that it's always about an analysis of work and making visible what people do. The idea that I understand from Carl that he discovered from Dorothy E. Smith's work. And MPT promotes the recognition that implementation needs to be seen as much more than people working together to enact a practice. It involves them in work that restructures. So those central questions that follow from the application of MPT are: what is the work that actors do to create change? How does this work get done? And what are its effects? And in thinking about the voice of equity in implementation processes, we can ask of MPT, what is the work that is done which makes visible inequity or injustice? Or on the other hand, what is the work which makes visible opportunities to realize equity throughout the implementation process? So it opens an inquiry as to what work is actually being produced as we go along in our daily lives of work, of living otherwise, and potentially brings attention to the ways that we can restructure resources and relations as the changed practice is brought into existence with observable effects in the social world. And here I share a little bit of Carl and I's Twitter, where he talks about work and this notion that implementation science theories and models can help us understand that things that are natural and that seem natural and inescapable are actually the product of work. They're the translation of socially formed strategic intentions into everyday practices and can be modifiable. And so we shouldn't see inequalities, Carl says, and disparities as big structural inevitabilities, but rather, and I love this approach, as the product of generative mechanisms and implementation processes that can be identified and altered. Ultimately, collective action and collaborative work to enact practice involves work that restructures the conventions, rules, and resources upon which everyday work is built, and that is known as normative restructuring. And secondly, implementation processes can change the ways that people interact with each other and the different kinds of relationships that exist between them, which is called relational restructuring in the theory of normalization process theory. So MPT can frame the outcome of successful implementation processes as ones whose outcomes is the evolution of new structures of interaction and new shared meanings. So here I just captured, I'm gonna move because I know that my time is spent, but
5 minutes, just so you know.
Oh, actually, yeah, so well spent. So this kind of lists what I think might be outcomes that are relevant to equity in implementation research through the theoretical lens of NPT, paying attention to intervention performance, and realizing that successful implementation is going to be about restructuring and reinforcing new practice norms. As I mentioned, normative and relational restructuring. Now I have this last bullet in red because I think here, and this is something that I would love folks to think with me about, that the premise is that workability and integration of that new practice, new idea is important to embedding and integration. But I have a question when we think about when the new practice in the context of health equity is intended to disrupt a formal way of working and thinking and practice that may have been implicated in racial disparities. So how do we think about workability in that context? Because we don't want to just kind of substitute one practice or make it easily kind of switched, because in fact, it may actually be marking a very different way of practice, of operating. And so I think that piece kind of intrigues me to think about in health equity, in assuring equitable implementation. So this is a busy slide, but it was kind of fun because I think it gets me to summarize some of what I'm presenting here. And that is that this is from Shelton and colleagues when they described anti-racist implementation science, anti-racism implementation science. And so if we think about critical race theory as an anti-racism lens, and these core elements of implementation research, all of them important, but honing in on theories, models, and frameworks, we might pull out of that the NPT's kind of formulation of context plus mechanisms and looking at the outcomes in there. I've listed some of the variables that could be analyzed in the implementation research. And then also identify, and don't have time to actually go into the components of critical race theory, but thinking about how these different constructs in critical race theory show up in context, and particularly in mechanisms. How is intersectionality or looking to the bottom, centering at the margins, involved in coherence building that happens in an implementation project? So here I want to just kind of touch some of my responsibility to talk about what qualitative methods and implementation research, I believe, offer us, that, you know, this new knowledge that is sensitive to context, the unsilencing of voices through critical race theory really talks about centering at the margins and using perspectives that are not typically included and silenced and marginalized. Understanding social systems that generate or limit opportunities for equity and health, documenting racism and less visible and hidden and unintended contextual factors that ultimately end up shaping the implementation of EBIs. The qualitative approach helps us unpack the intersection of multiple social identities and helps us understand how that moderates access to power and privilege, impacting structures that affect health. As very obvious that it contributes to theory development and can offer just a more in-depth understanding of implementation successes and failures and the mechanisms of change, because I think through an analysis, as I think about a future project, I think that we might understand how the work relative to it being a strategy kind of indigenously is derived in the implementation project. And that we'd have an ability to see how an implementing team works with that given mechanism and what strategies they naturally develop. And I think in that way, the issue of generalizability becomes less of the boogeyman, and we're thinking about showing a process and demonstrating a process that implementing teams and implementation processes toward equity can undergo. So there, I'll stop there. There's much to say. As we used to say in church, we're not out of words, but out of time for sure. Thank you for your attention.
Thank you, Cory. That was fantastic. I've been making lots of notes. So we're going to move to having a kind of discussion. I'm going to invite Fiona Stevenson and Tiyi Morris to join us. And they've been listening. They get an opportunity first to make any observations or ask any questions they have. And then we're going to move to Q&A. While you're listening to Fiona and Tiyi, if you've got any questions you'd like to ask or any observations, please put them in the chat. And thank you so much to the people who've been sharing references with each other and really reinforcing and making links to the presentations. That's really appreciated. So Tiyi, can I come to you first?
Yes. Hi, everybody. There were two fantastic presentations. I just have to apologize a bit because I'm a bit sniffly today, so I sound a bit funny. But really great presentations. My first question is to Anne, and that is kind of spoke about the process of moving from kind of synthesizing what people say to starting to look at theories. And what kind of advice would you have to early career researchers who are kind of at that stage of learning how to go through that process?
Yeah, it's a very good question. I think a lot of the available methods for qualitative analysis are very good at signposting the process of getting to know the data and making initial notes and the initial sort of charting out of potential themes. But it's sort of when you're at that point, and there's a huge amount of work, I suppose, in that. And I think sometimes projects are slightly under-resourced, and almost a combination of, getting through that hard part. You can't get to the second part without doing the first part, obviously, and it takes a lot of time. But I think it's been, like, from my perspective, the learning was I just hadn't at that stage of my career, didn't have a full understanding of that deeper qualitative analysis, that higher level analysis. So knowing it's there is, I suppose, the first thing, and then trying to build it into the time frame of the qualitative work. And there are very good resources. There's a very nice article in UFlick has a very nice edits Sage collection of books on qualitative research, and within those there's a very nice article about data analysis by Gibbs, and I found that a very helpful resource for articulating, moving past that first stage of understanding all the data and synthesizing it, and then trying to push past to the next phase of more conceptual analysis.
And I had another question for Anne, which was, are there any specific challenges with like innovative technologies when you are building theories, when you've got something completely new that's never been done before in practice, for example, and you have to build a theory and do lots of qualitative research on it? What are the potential pitfalls that you can identify?
Well, I suppose what I'll answer with maybe is I think the thing that made a difference, from my perspective, studying telemedicine, if that's what you mean, was a very innovative service, a very innovative technology. But I think actually the points that Cory's just been making about Carl's attention as a sociologist to the work that was going on by all of the actors involved in implementation, then at some level it's slightly less about what the thing is, and more about the processes of implementation, the work, the actions, the interactions, and how they were being described, enacted, understood, and so on. So I think it's once you have the right sort of approach to understanding implementation as a process of work, then the thing that's being implemented is secondary in a way.
Can I ask Cory a question as well? Okay, I'll scroll down a bit. I was really interested in what you said, Cory, a great presentation as well, about the potential for the implementation to change the world, the social processes in the world that we're in as well. And I was just thinking about potentials for it to go negatively as well and increase kind of inequalities and inequities. And I was thinking that might be a bit about our focus on, sometimes I'm working with digital health, and we focus a lot on individual patients and self-management and that sort of thing. So I was wondering what you thought about that focus on the individual rather than the social when we're implementing new technologies and things.
Oh, I love that question. You probably already know that. Because I think, in ways we find, and this is kind of a nod to the work of treatment burden, this kind of neoliberalism has increased the burden on the patient, increased the burden on communities who we're saying need an intervention for support, but the world doesn't change around them so that they can actually take advantage of that support. And so I do think that in the digital space, right, these mobile health technologies can intensify inequalities, especially when we're not dealing with, for example, the sense among some that those apps may not be trustworthy, or the algorithms themselves may be kind of have a founding in maybe racist ideas or disparaging ideas against other groups, and just not understanding the life of others, but saying, here's this, do it and get better. There's this the idea of methodological individualism that that has a strong kind of hold on social sciences that always brings the person back to the individual. What I like about NPT is that it really talks about this kind of collective approach, this collaborative approach, and brings in a much broader kind of the broadness of our world. I think that's some of what STS, Science and Technology Studies, tries to address, I think, is to say that this innovation is not just to, linear to get us from point A to point B, but it actually kind of represents a change in the way that we see the world, the way the world operates, the way that we see our bodies and interact with our environments. And so I think all of those things have to be situated in the analysis, help to remove this kind of singular focus on the individual.
Okay. And then one last question to Cory was, so I'm a health economist. I focus a lot on outcomes, and you spoke a bit about outcomes. So how can we start to think about using qualitative to think beyond kind of the natural endpoints that we normally think of in our work?
Yes, I don't know. No, what I attempted to suggest is kind of a reorientation around what is an outcome, right? If we're finding that the culture has changed in ways, and I mean, we know you can quantize qualitative and you can qualifies, right? So we know that those things can happen, but I think this notion of thinking about processes of change and what happens as equity is the top consideration, the critical consciousness that is raised. This is some of what I'm talking about, that not only gets us to folks who are able to manage their diabetes, but also kind of helps us get at these notions of justice and dignity and humanity that may actually lead us to a life that's beyond the office or beyond that particular interaction with the intervention. So that's what, and some of what I mean by it as a tool for justice making, that it can serve to improve the quality of services, but also in a way helps us chip at the kinds of oppressions that resulted in those disparities in the first place. So, and how do we describe that? How do we kind of fit that in our research proposals to get funded? I'm not quite sure yet, but I think it requires that we definitely think differently about it. And I think the implementation process and in qualitative work helps us get at the hows. As I often like to say, my mom and elders in my community teach us, it's not what you say, it's how you say it. And so if we can get into that space that I think implementation offers us for the hows, helps us to really touch humanity, our humanity very differently. And I think touching that humanity is imperative for how we think about and design care.
Thanks so much.
Thank you.
That was great, thank you. Fiona, I'm going to come to you next.
Thank you. I was going to go to Cory first, actually, just following up from what you were just saying. I just wondered if you'd, the idea that you're using critical race theory alongside MPT, I just wondered if you could talk a little bit about any of those challenges, given that both of those are, have their critics themselves as they sit on their own. And I just wondered if you could say anything about how you've addressed that, or whether you've had any challenges come to you around using those particular approaches.
Not just yet. And if the challenges exist, I'm probably not paying attention to them. Because I think what I'd like to do also with your question is to talk about like that controversy, which is essentially, particularly in the American context, but I think beyond America, that racism is ubiquitous, that it is involved fundamentally at some level in our social systems, and that to not pay attention to that in this kind of colorblind way or a race neutral way, or thinking that, thinking through implementation projects as if we're in a post-racial society is actually damaging and harmful. And so I don't know, I haven't quite paid attention to, I'm aware of the kind of political volley that happens around, but I then again, Fiona, I'm like, the record is in the history. Like, I mean, what else do we need here to demonstrate that's what it is? I have thought about how it might impact my ability to fund work. And then I think it also is worth thinking about different implementation teams that you might be working with, how sensitive and how ready they are to engage those kinds of conversations. So that's why I think there might be some considerations in that space. I think raising consciousness is probably an important way to think about that, and may even show up right in our generative mechanisms, right? So as we explore coherence and that sense making, how are groups grappling with the question of racial disparities, for example, may give us some insight about how equity through that particular intervention or as a process in and of itself can be embedded and sustained.
Yeah, absolutely. That was going to be my next question. So I'm going to move, in the interest of time, I'm going to move on to Anne. I was quite interested, Anne, in I loved your journey. Both of you did lovely presentations, and I really liked that journey. I was quite interested in that qualitative, quantitative dichotomy that you started with in there. And I suppose I'm just going to challenge very slightly and say, do you really think there has been a shift? But I just wonder how far you think that shift has really come, because in terms of some of the conversations I've been involved in terms of implementation science in particular, it seems to be some of the most divided between people who take a very quantitative approach and people who take a very qualitative approach. So I just wondered if you could talk to that a bit, because it seems a very strong dichotomy. I guess certainly I wouldn't think that debate has been put to bed, and it's not over. I guess for me the shift is there's a big tribe of us now who understand and value and promote the role of qualitative research in general, who promote it in health services research, and who promote it in implementation science. So I guess I would say I don't think it's as lonely anymore. And that's the shift. We're actually in the unit that I run here in the University of Limerick, we're an interdisciplinary unit, and there's at the moment about 12, 15 people in it. And we're all interested in primary health care, equity and participation, public and patient involvement in health research, and actually the qualitative and participatory arts-based researchers outnumber the quantitative ones. So, I think the difference is that you can find your tribe more easily. And I think it's sort of, you're right, it's sad and shocking that that debate is even there at all, but find your people and do good work, I would say. Yes. Annette, do you want to move on to the rest of the room? I'm just wondering to give people an opportunity.
Yeah, you've got a couple more minutes if there's anything else you'd like to ask, otherwise
I will ask actually, Anne, just one more thing actually, just around the one bit, and I may have missed this. So you had those consultations, but I didn't hear very much about what you said about that kind of observation of what was happening as opposed to what people were saying. And I just wondered if you had anything to say on that.
This is now the teleconsultations and video recordings. Yeah. So unfortunately, they never got fully analysed, is the short answer. Which was due to the scale of the data set we had and the length of the project. And we had, so we didn't actually do intensive analysis of those, which was unfortunate. I wonder
if you can just, I was just going to say, can you say a bit about whether you think that is a role, or whether that kind of observational data hasn't played as much of a role in the kind of work that you've done, either ethnographic observation or observation of recordings and things?
I think it's hugely important, and in fact in the work we've been doing since in relation to interpretive consultations, it's one of the things that we've always said would be really valuable, to actually be able to video or audio record interpreted consultations, which would be my primary interest now, because of course the triad the way that shapes the actions and interactions between everyone is going to shape exactly what's being said, and then also inform our understanding of the work that's involved in implementation. So I think it is a gap in the literature, and we're actually working hard at the moment on an ethics application to audio record interpreter consultations in general practice with Ukrainian refugees in Ireland and Ukrainian interpreters, and it's proving very difficult. So hopefully we'll have a positive response on that. Okay, great, thank you. Right, I'm going to pass back to you, Annette. Thank you.
So thank you very much, Fiona and Tiyi. Those are great questions to set us up. Would anyone like to ask a question? If you could indicate by raising your hand, that would be great, and I should be able to spot those, or putting something in the chat. Tim.
Yeah, hello, can you hear me?
Yes, yeah, we can hear you.
Okay, so it's about a sense of temporal orders here and the potential and possibilities for change. Because what we've got here in both cases, both speakers are talking about actually substantive structural restructuring is needed to engage these things. And I'm concerned that research time and research project time is a very small moment and a blip. And actually, how do we start to do more thinking about how we think about change over time and other kind of things? And it echoes back to something about the outcomes thing. If we think about the outcomes, we're looking at radically short-term outcomes. And even the health economics is doing radically short-term outcomes. In MPT terms, we're focusing on the introduction. We're not looking at the embedding and sustaining. So how do we kind of shift and have maybe, yeah, and that becomes really, really problematic, because actually, yeah, so there's something about the temporality, and there's something else about modesty, but I'll shut up because I could keep going.
Would Anne or Cory like to respond to that?
I wouldn't mind coming in. Thank you, Tim, for your question. It's really interesting, and I think, you know, what comes to mind for me is that in the EU Restore project, because it was prospective, longitudinal, we were following the journey from the start. I think we had a lot of hope and anticipation about the sort of deeper knowledge that would elicit. But what was, I think, frustrating was, even with that, you know, well-funded 4-year project, quite extensive fieldwork phase, the fieldwork phase itself was almost 2 years. We were actually only fully understanding the structural macro level barriers to the implementation work towards the end, because of our concentration on individual action, collective action, collaborative work, co-learning, and the participatory methodologies were very invested in supporting dialogue and co-learning between the as Cory says, the implementer team. And that was a lot of new learning and knowledge for us about what, in fact, the actors could progress themselves with their own collective knowledge and resources and agency. But what became very clear is that the journeys came for us to the end was that these macro level barriers were really significant. So one of the main barriers, so I'll give an example. So in the implementation work, in the Irish case study, they wanted to make sure that the GPs actually had experience of working with a trained interpreter, because they hadn't even had that experience. And the resources of the migrants within the implementers team meant that the GP could have that experience. It was transformative. The GP said, I never knew, you know, how effective interpreters were, and I would now like to use one going forward. But the whole setup, the whole funding model for primary care GP services in Ireland means a GP can't do that. There isn't clear reimbursement, and if you had successive interpreter consultations, it would disrupt time with other patients and disrupt income. So we started to see the influence of biomedicalism, ethnocentrism, racism on the implementation work, but it was at the 11th hour. So I think you're right, that it's sometimes the more interesting, maybe the more ingrained structural barriers, you know, are harder to see at the start. Although then again, you could say, I think it's true that we need to be looking at these issues much, much earlier on in implementation research. So maybe by knowing the relevance of them more clearly, looking at them earlier will overcome some of that problem.
If I can add to that, I think, Carl, when I talk with him and I send him these emails, so I think I told you I was a preacher. So I got my "we shall overcome" thing heavy on me. And so Carl will be like, always, I feel sometimes kind of tempering my enthusiasm appropriately, right? To understand we're not, can the theory do this? Can the work actually accomplish that? So I think your point, if that's where you were going with a point about modesty, I think, it's well taken. Also then, I'm understanding that the changes that we have seen in the context of Black Lives Matter, in the context of civil rights movements, have been won over time. And we didn't get here overnight. And to get out of that means that we're going to be making these incremental kinds of changes. And so that's why this focus on processes and relational restructuring is so important, as I understand it, as far as describing it as prefigurative to the kind of world that we want to live in, to the kind of relations and interactions that we want to see. And I think that time scale does become a challenge for us, but then we need to put that time scale on the scale of transformative change. And so, I know that there's this pressure to see, changes happen rapidly. And there are methodologies, I guess, rapid ethnography that kind of accommodate the need to be situated within those time frames. But I also think that there's also an important observation in stakeholder engagement work and public participation. And you probably recognize where folks talk about not just approaching communities because you want something from them or because it's like a transactional process, but understanding that in some cases you may be working with, and this is in the context of population health, working with folks over some time as they start to identify what they see as the problems, where they want to begin in designing strategies to implement practices, new changes, and innovative ideas. And so I think that all of those kinds of ideas are important as we think about both time scales and also modesty.
Yeah, I just personally think we should be less modest. I think I think there's a level of people take the path of least resistance a lot of the time, the most modest, the most manageable, when actually sometimes we need to be a lot more radical. But then there's problems around funding around that as well. But hey, I will shut up.
I'm glad to hear you say that, Tim, because I'm going radical too. Yeah, absolutely.
Yeah, I think that point, Cory, you're making about the participatory approaches, if you're talking about meaningfully involving any community, patient, or group in the public with research, and particularly with implementation research, it is, if it becomes instrumental and transactional, that is really problematic. It's unethical and it's less effective. And it's something about, I suppose that is a shift in the health research ecosystem. If we're serious about health equity, if we're serious about research, implementation research that can lead to transformative change, then the ecosystem has to have the funding mechanisms for academics and their community partners to work together over long periods of time. So there's a lot of good critical literature in the participatory health research, community-based and participatory research field, which would say the ecosystem is a structural barrier to meaningful partnerships for meaningful research that can be impactful over time.
Yes.
Yeah.
Wow.
Oh, does anybody else have a question? I'm going to just quickly ask mine, if that's okay, which is about kind of the knowledge that lives in communities itself. I mean, obviously we encounter that through stakeholder engagement, but the kind of privileging of scientific knowledge in processes of change, particularly within implementation narratives. And I wondered whether you thought that was being challenged at all. We've talked a bit about qualitative research, but also the kind of, the literature, for example, from kind of Canada and Australia about kind of Indigenous knowledges and Indigenous ways of knowing.
Well, sorry, I'm hugely interested in this at the moment. Just got a funding application rejected, but it was kind of along that line actually, Annette, which is what are the methodologies that we're using to create participatory spaces for research and implementation. And if those participatory spaces are dominated by Western cognitively driven methods, well, they're only likely to get us so far. When you look at the literature and arts-based research, and here in Limerick, we have a particular interest in the role and potential of music and singing as tools and methods for whole person engagement and releasing and eliciting new kinds of knowledge that we don't even know is there because we haven't even tried it yet. So this would fit very much with that the literature, that there are other ways of knowing, there are other ways of creating space, being in space together, co-learning through different methods, and I think that would be extraordinarily interesting.
Yeah, and I'm so glad you said that, because it reminded me, as I mentioned, the conversation around this notion of there doesn't yet exist a blueprint, and another part of our conversation, my kind of pushback against that was, well, perhaps, us scientists, we love to say we invented something, right? We figured it out. But I mean, in fact, the truth is that actually that blueprint may exist, not in the ways that we structure knowledge, right? But that they exist because these are communities who have been fighting and dealing with marginalization, oppression, and limitation of resources, and have community-based organizations that have rallied around to help fill that gap. And so I think us turning to communities might, to Tim's point, be able to help accelerate that process when we let that speak back to us, right? And I feel like that's a part of the implementation role. My role as an implementation scientist is as a translator, not just translating from the academic to the practice space, but also being able to draw from the practice, the lived theoretical, to be able to inform our work and our understanding of what's happening in those dynamics. Another thing that I appreciate about NPT, because I love that it's not so prescriptive, that it actually goes into that space saying, so actually, what did you do about that? Or didn't you do about that? And then we are able to then link strategies from that might be useful, I think.
Yeah, and I suppose if you think again of the importance of, the involvement of all the relevant stakeholders, but that they're working together collectively, with this common goal, if you like, and that they have different perspectives, expertise, resources to make it happen, essentially. Like, it's really interesting that the literature, music and singing is that it's one of the fastest tools for social bonding, but not in research settings, but in community settings, in intercultural community groups. It is one of the fastest methods of creating social bonding between people who've never met before. And I think it's quite interesting to think, what could you do if you could capture that and bring it into a research space that then had a group of stakeholders committed to driving implementation forward, and that they're coming from diverse backgrounds and therefore have diverse strengths from within and outside different margins of society, within the establishment and so on. So I do think there's a lot of interesting work to be done, pushing the boundaries, yeah.
I noticed that Caitlin Lord put in the chat some links to social design thinking, and that feels like another way, so another set of colleagues in another slightly different space. I wondered if, Caitlin, if you are still with us, whether you want to say something about that.
Yes, gosh, I feel like an interloper in this group of researchers. I'm a lowly project manager in a commissioning organisation just doing stuff. But maybe I'm the missing link, because I am really interested in qualitative, data and how we use some of these techniques in practice. We've sort of been exploring very, very early tentative toes in the water in service design, because that's, what we in commissioning do, and how to sort of challenge the sort of current paradigm in our organisation, which is very sort of new public management, data driven. We in our team, we sort of feel like a complete outlier. So I think it's not to underestimate the challenge of changing the thinking of all the people around us. And social design is just something that we've tried actually in a tiny way with a group of men around weight management, recognising that they're not attending a lot of the community weight management programmes, and that there's actually very little out there about why men don't do that. What do men think? Is it about their identity? Is it about their lives? Is it about their context? You know, what education isn't the answer. They know what they need to do, but they're not doing it. You know, so we drew on Hilary Cottam, who I'd really recommend anybody read her book, Radical Help. I think it's how do we change the relationships between sort of state and welfare states, about getting really into and alongside the people that you're designing for. And really the most radical thing that came out for me from that as a sort of designer in a system is working with those people to define the problem. And because I think that's where we're sort of going wrong, is actually hearing those communities' views about what the problem actually is, which might be completely different to what we think it is. And in fact, we designed a programme as a result of that with them that they were involved in and are now supporting continuing, which wasn't really about weight at all, but was about men's identity and mental health. So yeah, it was just a little toe in the water. But the other thing I'd say is, it's just as somebody in the field, it feels like such a disconnect between you guys in this space and us as practitioners. And I just would really hope we can bring some of the techniques that you're talking about kind of really alongside practice, maybe to tackle this fact that you're not perhaps surfacing some of the organisational obstacles to change that you would probably be put front and centre if you were working alongside in the field of some of the people like myself who have to actually sort of make it happen.
Thank you, Kelly. And there's a great point, a real challenge that comes to kind of implementation research, that the disconnect potentially of our work on implementation research and implementation practice. And there's a lot being written about that at the moment, how we must try not to become divided and two separate communities not talking to each other. I'm going to give Cory and Anne an opportunity to make any last observation before we wrap up. So Cory, can I come to you first?
Yes, I actually just wanted to, my research agenda, this was something that I thank you for this. First of all, hey, everybody, thank you. This was fun for me. And I hope to see you on the other side of this work, having moved a little further. My research agenda advocates for a resistance in implementation science in a way that struggles against racial oppression and against the harms of hegemonic knowledge and the ways of knowing that legitimate racial oppression. And Boaventura de Sousa Santos articulates the way resistance brings about an insight that escapes scientific hegemony by recapitulating Bourdieu's notion that established social science creates false transparency that prevents further innovative research, saying, that established science always stays in the way of emergent science. But Bourdieu's recommendation, and I leave the group with this, is that he concludes that one must practice a science against one's scientific training as much as with one's scientific training.
Thank you, Cory. That's brilliant. Anne?
Yeah, that's really nice. It's sort of, I think it's connected to my closing comment maybe, which is about, the Kuhn's work on paradigm shifts. And I think that the common thread for me in implementation science and the really powerful potential that I see in participatory implementation science is that, time and resources matter, because we need to innovate on the methodologies that we use to create and enact participatory spaces. And it's very interesting in some of the work we've been doing, when you do evaluations, you talk about using very innovative participatory tools like participatory learning and action research, or even arts-based methods, and people are inclined to say it's really interesting, it's really different, it is eliciting something fresh, but it takes so much time. And you think, well, you know what? A randomized controlled trial takes time and a lot of resources, and the whole health research ecosystem is set up to support that. And I hope that, yeah, in the next 10, 20 years, that the ecosystem will also see the value of supporting much more radical, diverse, whole person methodologies that harness dialogue and co-learning, because I think that will really make a difference.
Thank you. So thank you both so much for such brilliant presentations, and also for giving us so much food for thought. And as a number of people have commented in the chat, the sense of maybe many people in the room finding their tribe today, if they hadn't found them already, because it's really important that we have a kind of sense of community around this work, that we connect with each other's learning, and there's so much scope to learn from each other. So thank you for that. Thank you also to Tiyi and Fiona for your questions and comments. They were great and really great stimulation for the discussion. So I just want to finish up. Could we share the slide about the other webinars? So there have been a set of webinars organised by ARC North Thames, all of which are posted online. I've just put the link in the chat, and this one will be added to the set. So if you want to watch this again, as my son does on double speed, if you're busy, then you can watch any of these webinars. They're all really, really interesting, looking at this area from some very different angles with some great speakers. So please do check those out, and we'll add this one to the set. And also, if you have ideas for other webinars that you would like to hear, that we're open to suggestions, so please get in touch. Our email address is at the bottom here. And I did really want to finish off by saying a massive thank you to Carl. This webinar was his brainchild, and he spent a lot of time thinking about what was going to be covered and thinking about the great speakers we've had with us today. So a really massive thank you to Carl. I know if he could have been with us today, he would have been. So wishing him the very best for a speedy recovery. So thanks everyone for your contributions, and also for all the sharing that's been going on in the chat. I always find we'll try and capture some of that so we can share with others afterwards. Thank you. Bye.
Thanks very much.